Hello, everyone, and thank you for joining us this evening. I'm joined with Dr. Andrew Fish, Dr. Jenny Kabir, Dr. Peter Fairbairn, and Dr. Stuart Kilner. We'll be going through question time on sinus augmentations. We have got some questions that have previously been asked before signing up, but if you have any questions you'd like to ask throughout the webinar, please type them in the Q&A box at the bottom, and I'll pass you straight over to Stuart to get started. Thank you, everyone.
Hi guys, how are you all doing? Thank you for taking a little bit of time out to send us some questions in and time out from a really nice evening in the UK. It's not often we get a summer evening like this. But we will start with the first slide, which is a first question. So I will move on to this first slide. We will. There we go. So one of the first questions that we have is describe the techniques. So I'll be reading these questions out and our three clinicians on the other side will be answering our questions for us. So describe the techniques used in ridge regeneration with sinus lift with a particular focus on the upper premolar region. Would anybody like to take the lead on that one?
I think probably one of the others, because I don't really do that much ridge preservation stuff.
I was going to, I'll share one or two cases later on, but for me, this is the most important question of the evening to start off with, because the area above the ridge is more important in my eyes than the actual sinus itself. And I'll go through that and share. Because if we can actually help the host grow bone vertically and improve the keratinized soft tissue, this is the key to sinus augmentation. It's not merely what we grow and what we can regenerate in the sinus, but what we can regenerate vertically to improve the aesthetic platform, so to say. So I do this routinely, and I'll show a whole lot of cases later. But what do you feel, Jenny?
I find that Ethos is a great product, and it's pretty safe, especially because it's bacteriostatic. It doesn't need a membrane. Once you get the knack of handling, it is quite easy to use. So I know there's a lot of talk about immediate placements and things, but if I've got a big molar infection, paw bone, I'll always socket preserve with Ethos and allow the soft tissue to regenerate. And recently I've not been completely closing over the Ethos either, allowing some closure by secondary intention, so you get more mucosa for when you go in second time round. So the advantage with Ethos is easy to use, is bacteriostatic, although you definitely clean out any site as well as you can with the swallow supply some degranulation burrs, which are excellent. But the Ethos just regenerates really nicely and quite rapidly, and you get great keratinized attached gingiva forming. So when you then go in secondarily, it's really beneficial. It kind of minimizes the amount of sinus manipulation you might have to do in that area. So to summarize, always allow the host to kind of heal, help the host to regenerate, and give it a bit of time. Ethos is ideal for that kind of scenario. So yeah, pop it in the first instance.
Yeah, as I said, I'll show some. When I show up, I'll show you the whole area, what I mean about regenerating the ridge as well as the sinus. Okay, what's the next one, Stu?
Can I just go back to, we had a question there that I just read.
Yeah.
Someone was saying that whenever they've ridge preserved like they do, they get a lot of pain afterwards, more so than obviously doing nothing. I found this as well a little bit in cases, and it wasn't because of grafting with Ethos. I think it was the overcompression of the graft, packing it in too much.
Yeah, this is an important thing, is that this is not a material that you pack into a side. You know, certain materials, it's a more of a regenerative material, and therefore I never, you know, people talk about using pluggers and whatever. I never really do that. Let's see.
I use the gauze to dehydrate it, and that's about as much pressure as I do.
You know, really, Andrew, it's a real. I agree with you. That's a real important factor, is to just apply pressure, not too hard. This is not something you pack in, and I think these are habits that people have developed over the years, and it's quite difficult because you have to kind of change, look at things differently. Right. What is the next question there, Stuart?
So the next question here is, how long do we wait before placing implants if we use Ethos as a graft material? And can you explain the long-term stability?
I tend to wait about 8 weeks, but I think you can go in sooner than that, 6 weeks. It really does regenerate into host bone, and it resorbs quite rapidly. So on an X-ray, it may appear that there's not a lot of bone, but that's just the calcium sulfate disappearing away. And then later it surprises you as to how much bone you can get. So yeah, that's what I do.
I wait. If I was to ridge preserve, I'd wait 3 months. That's part of the reason why I don't really preserve that many ridges, to be honest. I've become, mainly over the past 2 years, a big fan of the early delayed approach. Soft tissue healing first and then go back in about 4 to 6 weeks. I think with the advent of southern implants and my use of them, with the Max as well especially, and I love tissue levels, they're quite a wide platform, so they're quite a wide implant, which means that you can utilize, you can place them in those sites. I don't push it to the point of immediacy with molars because I just don't see the point in taking the risk. It's not a cosmetically driven tooth. Timescales wise, I don't think patients have never been desperate and been more than happy to wait a matter of 3 months, which is what I kind of generally have done forever. And it's kind of recently, since I've moved to Southern, that I've started to go to this 4 to 6 weeks. What I've found best for this is in the aesthetic zone, with the advent of using, PDS sutures as well, is that if you can get soft tissue coverage, it means that site underneath is bacteria free, otherwise it wouldn't have healed. So you've got this really kind of clean site. All right, you haven't got bone growth in there, but you haven't got that resorptive phase either. And I think you only really get that after that 4 to 6 week period where you tend to get more collapse. So if you can go in,
I think just to highlight the point that you're making, through that early delayed approach, you're really utilizing the best ability of the body to heal, because you're allowing for the fact that the soft tissue in the gum heals faster than the bone. So you allow the soft tissue to heal over the top. You then got that to close it. You again got that to play with, but you're getting in and using and working with the bone before it starts to resorb. So it's that perfect balance.
I think a combination of using VersaBurs and osteodensification tools can really help that 4 to 6 week. And for me, when I use conventional bone graft materials other than Ethos, I'd give it that 3 month marker. But now with Ethos, I find I can go in much faster, and the soft tissue healing is far more favourable due to the Ethos as well. So you get nicer soft tissue healing as well.
If you, in my opinion, if you're using conventional graft materials and grafts, you have to wait at least 9 months.
Yeah.
It's not like 3 isn't nowhere near enough, so it's that's it's just
this goes back to the sinus where anything will really work, because you're only taking an x-ray, and x-rays are notoriously poor at telling what's really going on regeneratively. Anyway, what's the next question there, Stuart?
So the next question is, do you perform immediate or delayed implant placements? And I suspect
this is into sinus.
Relation to the sinus. Yeah, with relation to the sinus.
Yeah. Well, I always like to place immediately. I'd probably place 1 or 2 delayed a year. That's all. And on Wednesday I did 5 sinuses in 1 day. So I like to get the implant in because it's helping tent the system up. If you're getting a material that's turning over to host bone, pneumatic pressure is huge, and people don't understand it. It's like trying to graft in the posterior lower mandible, where there's a lot of movement. In the pneumatized sinus, there's a lot of pressure on the site. So I like to get the implant in as soon as I can. So I
Well,
prefer
I was
mediate.
going to ask you for some tips in terms of what do you do about lack of soft tissue in that large molar area where you're putting an immediate implant in, just a large healing?
I leave it the delayed process. When you do something every day and you've done it for 20 years and you're doing a number of cases, you just sort of follow the format. And that's why the protocols of delayed immediate is probably better than straight immediate. Yeah. Just for predictability.
I mean, as soon as you take a tooth out through the secondary intention healing over that extraction site, you get so much nice keratinized mucosa. If you just follow that delayed approach, there's always an abundance of soft tissue, and very rarely have to do any soft tissue graft.
I've had some really good success with this. I can't believe I've been so bloody stubborn about getting on the bandwagon with it, because it's literally been about a year or two I've been doing this early delayed approach, and it works. It's lovely.
Yeah, it's Andrew.
It's
just it just gives you predictability, and in the UK we need that predictability now.
You just get a lot of legal. It works. It works very well.
The best of both worlds.
And makes life easier for the surgically because of that soft tissue element.
Yeah, and everyone is in such a hurry, but if you just wait a few weeks, you've got the best of both worlds.
I used to wait 3 months, Peter. So
wait till whenever you're comfortable. I agree.
Yeah.
It's such a race at the moment to try and be more immediate than the next guy. But in the UK, we need predictability.
We do. But I'm also finding I'm doing a lot of immediate loading now, as well as I know that you are.
Yeah.
And I'm finding that. I mean,
you know what? We've learned a lot of lessons about immediate loading. And we've learned about placement of the implant, position of the implant, how we can do this. There's so many changes are happening. Often I explain it to my patients. It's a little bit like mobile phones. You look at the Nokia to now with iPhone X or whatever, and it's just moving so fast. And the development with inverter and whatever. An inverter is a hard implant to actually use, but once you grasp it, again, it's a real revelation. But it's much harder to use.
It got me out of a pickle on Friday.
These are just all new developments, and so our concepts are completely different to what they were. I've been grafting sinuses for 27 years, and everything we do is similar but completely different now.
So to summarize, I think we're all in sync of what we're saying. We extract the two. I personally place I degranulate, I place some Ethos in those extraction sockets very loosely, and then I dehydrate the Ethos on top just to make sure it's a bit stable, allow soft tissue healing and go immediate delayed basically. And catch it at the best point of both worlds, whereby you're not losing the host bone, but you're able to kind of regenerate and get in there.
Yeah. So the next question, Stuart, is success rate.
So in the discussions that we just ran through, there was one that just came up, and it was somebody asking us, Andrew, if after compressing the Ethos, do you cover the site with anything?
Well, I don't think you need to, but I used to, from a common sense aspect, and this was the same with my immediate placements. So if I was to remove anything, usually anything single rooted up to a premolar, I would always immediately place at that stage, and I would fill in some Ethos. And at that point, I used to use a collar cone, basically just pressed over the site, held over as a figure of 8. And I would do the same for, say, if I was desperate to preserve a molar. I use collar cones, to be honest with you, because they work and they're cheap, and I don't see a vast improvement in my gain by the time I come to it 4 to 6 weeks later. So that's the main reason I don't ridge preserve with Ethos. But if it was going to be one of those situations maybe where I was going to wait 3 months, I would just try and get as much as I can. I would still put a collar cone over the top, compress it,
yes.
stitch over the top.
I mean, we're talking about ridge preservation. but actually we're utilizing this protocol where we're getting in underneath the gum once the gum's healed, before that alveolar bone has really started to resorb.
Yeah.
So rather than us waiting too long and letting that bone.
This is the key to everything. It's a preservative regenerative approach. In other words, we're preserving hard tissue before the modeling really commences, and we're doing a regenerative approach by improving the hard tissue.
And can I just confirm that you're not ridge preserving with Ethos if you're going to do an early delayed approach, are you?
No,
Exactly.
I very rarely ridge preserve immediately, Andrew.
Yeah.
I just let it heal for 3-4 weeks. Then I go in and deal with the site. If I need to ridge preserve, I do. If I place, I very rarely ridge preserve without placing an implant.
Yes.
You know.
Yeah.
Yeah. I mean,
So
you
what?
know,
Sorry, go on.
yeah. So, you know, this is the sort of essential protocol is what gives me that 99% security, and then I can push from there. And that's why I'm doing more immediates. We're doing more with cervico. We're doing more with, but because we have the confidence to know we can do it. The greatest thing about going to work is doing 2-3 grafts a day and absolutely knowing the results you're going to get. And that's why the delayed immediate protocol gives you that total comfort zone.
Yeah, there's just no worry with it, is there? It's just a nice, relaxed.
You know,
approach.
no. Okay, what is the next one? It's because there's quite a few questions, so let's get through them.
So in cases of large labial defects, do you graft and wait for the implant placement, or when should you place and graft?
I always place because the implant itself is semiconductive, and according to all the research by Sasaki and all the thousands of cases I've done, I think the implant itself upregulates the host response to bone metabolism.
Agree.
So yeah, like Peter's been doing, and his case examples are amazing, where you have a slightly wetter mix, place the implant, a wetter mix on top, and then a drier mix. But yeah, place.
Can I just add to that? That depends on the implant system.
Right.
Yeah. You know, Andrew, years ago, I used to just say a screw was a screw. But I've actually learned by using more systems than I probably should have, that it's not. That implants are very much part of the system. You're totally right.
I know this from experience with the inverter, that for 10 years I've been placing Ethos as a wet mix around BLTs for Straumann with no issues. Dry mix over the top. First 3 cases with the inverter doing the same thing all failed catastrophically, and the reason for it is the degree of insertion torque and compression. Is what I've done.
You have to.
Yeah.
The inverter has a uniquely, unbelievably high compression factor.
I just created this inert layer of Ethos that was not able to vascularize, and it just like this kind of this pseudo granulomatous layer. So they didn't fail due to infection, and the patients didn't even know they failed, but they just didn't integrate because of that. And now I've placed over 30 or 40 now over the past few months with 0 failures.
So have you changed your technique to use your current implant system with Ethos?
Yeah, exactly. So I don't pre-fill. I don't pre-fill the sockets with Ethos with the inverter implant or any.
It's a very unique way of actually doing implants inverter, and it's got huge benefits. And you know, I learned a few lessons. Now I don't place an inverter without the onion. You know, to place it directly.
Yeah.
You can't place them with ratchets. It just causes too much of a talking. Anyway, let's get on to the next question.
So then the next question is, does Ethos fully turn over into host bone, and how does it generate new bone in the sinus?
Well, you know, the best way of answering this question is that I routinely just push implants, you know, Stuart, into Ethos with a cover screw. And I do this once a week. And I've been doing it for 7 years. So, and then I load them at 10 weeks. So there's no bone to implant contact and no primary stability. And I load them all, and I've had one failure in a few hundred. So yes, it does turn over to host bone. We all know that beta TCP fully bioabsorbs. There's there are hundreds of papers on it. And I think it obviously is just it's not the graft that's regenerating the new bone, it's the host. It's the host mechanism and the host tissue. But that's why I sort of say in the sinus, if I can just push an implant into a socket with no primary, then in the sinus it must be good, because anything works in the sinus, because we can't really check unless we take core samples, and no one takes core samples. Everyone just takes a CBCT or an X-ray and says, look at the bone. Well, CBCTs can't tell you what the quality of the bone is.
It looks like bone.
Yes.
It probably is bone now.
Yeah. I mean, you know, it's the old question, Stu. You know, if you want a good X-ray, throw a whole lot of choose your animal, porcine, horse.
I mean, the sort of old, if it looks like bone, it's probably bone, kind of doesn't really ring true on a radiograph, does it?
No. Well, I mean, as a doctor, that doesn't make sense, but I agree. Yeah.
I mean, you want something biological and functional. So, I mean,
the best X-ray you're going to get is if there's no human bone.
Yeah.
You think about it, you're going to get a fantastic X-ray as long as there's no human bone. Human bone is not that radio opaque, as contrary to what people believe, and especially at the early phases where mineralization is a bit of an issue. Anyway, should we go on to the next one? Because I know there's a huge number of questions.
So the next one is how. So this is in regards to sinus lift surgery. So when you're mid sinus surgery, how should you manage a membrane tear when performing a sinus lift? And if there is a perforation, do you perform the sinus lift procedure again in the same location?
Quite a lot for this question depends on the level of tear.
Yeah, how bad the tear is.
How bad, there's so many dynamics to answering this question.
Yeah, you can have those tears when it's like a soap balloon and you touch it and it just goes pop and there's like nothing there. And the only thing you can do there is suture close, come back another day, you know.
Yeah.
I mean,
if you're going back to managing tears, exactly. If you are peering up into the sinus as a whole, then you're pretty screwed. But anything less than that, you can fold the membrane on itself. So if you're doing a lateral sinus lift, you can often fold the actual membrane on itself to cover the tear, if you know what I mean.
Yeah, that's one of the best solutions.
And then beyond that, then I would use BioGuide usually. I mean,
you've got to remember that even Salah of Versa says that probably 25-30% of all internal lifts are tears.
Well, that's a common statistic. So yeah, so at least 20% of CSLs have torn without you knowing about it, which kind of leads me on to why I use Ethos in sinuses.
Yeah.
Because
you don't want to get burnt.
Well, you just don't. No matter how, I don't know if there's much evidence out there for xenografts and sinusitis, but I've literally had zero problems with sinus lifts with Ethos ever.
Yeah, I've been lifting sinuses with calcium phosphate, calcium sulfate. So initially my own mix, then Vital, then Ethos for 22 years. And I have never, and I do a couple a week, I have never had one sinus infection in 22 years. You know, not one.
I've never had to refer them for a washout or anything.
Yeah, nothing. And again, that's a big thing, that if something goes disaster, it's not a disaster.
It makes sense. You know, if you're sticking a load of dead cow that is ceramified and glass in somebody's sinus and there's a tear, and that floats around, it's going to get lodged, and it's got to become a bacterial magnet of some degree. And
The
whether
thing
it
about Ethos,
actually flushes through the ostium and it's all good, fair enough. But at least I know with Ethos is that it's going to resorb. It's naturally going to resorb. It's got its bacteriostatic nature about it. So it's safe as houses in the sinus. It is absolutely the go-to material for sinuses, I think, for anybody.
that security.
Yeah,
It's just safe.
yeah,
Proper safe.
yeah. That's safety is a big word.
Yeah,
It's really hard to describe. I mean, you've all read Michael Norton's research that he's published on sequestration and necrotizing sclerotic sites in and sequestry formation in sinuses. And coming from Michael, that's unusual, but it's what can happen. And I also think the long-term thing is if you've got a long-term turnover to host bone only, it's a lot safer than having foreign material, which can't maybe impede the turnover. And when the turnover of your natural bone is impeded, our skeletons are turning over all the time. This can lead to this situation that Michael Norton has published now.
Yeah, and it's totally theoretically a lot more possible with something like a xenograft.
I think
you just reduce.
in the UK, especially where medical
Yeah.
legal is a huge consideration, I find Ethos has given me the confidence to do far more sinus manipulations and sinus lifts. Basically what Andrew was saying, it's bacteriostatic and it rapidly resorbs. You're not going to have some sequestered cow bone floating about, months and months later down the line that can set up infection sites going into the ostium. So Ethos is safe and the go-to material, and it works, I
mean, there's research on you can tent the membrane with an implant by itself up to 4 millimeters, and there you go. So I don't like the thought of that personally, but that's
I totally agree with you, Andrew.
But it's at the end of the day, I think sinuses are something that I find with my mentees and like the MSc students at Manchester and stuff, is that they're feared to death of doing sinuses and working in the sinus. But it's the easiest place, and it's the least headache. To give me a sinus all day every day over like a posterior mandible or an upper lateral. It's such an easy spot place, and it's so resilient. I mean, look at what zygomatics do to the sinus, and it heals, and it's all good. So if you're gonna,
it is. It's a very
flexible. As long as you use Ethos.
Pardon?
It's all good as long as you use Ethos.
It's just safe.
Yeah,
just a
Jenny, your lecture in Scotland was great, and I do feel sympathy for someone when you're starting out, and the difficulty of getting mentorship, and that's why I like what Andrew's doing at ICE, for example. Is it's all about helping people and hands-on. It's I mean, when you were telling your story of your initial sinuses. Sinus augmentation for me is just one of the easiest things to do, the most predictable things to do. But it does take a little bit of thinking and development and understanding. Right, Stu, what's the next question?
I've got another. Next question is coming up in a second, but just before we move on to that, I've got another one that's just been asked on how does the setting mechanism work in the sinus, and do you apply a dryer mix outside the sinus whilst applying a gauze to try and dehydrate the material, and are you placing at the same time?
I don't think it matters in the sinus. I think I tend to use a dryer mix. Costa does as well.
Yeah.
I've got a new Graft gun, as you know, Stu, and that's keeping me really happy. It just puts it anyway.
Can I share my screen quickly? Can I use a
Yeah. Let's do a quick screen share, Stu.
I want to show you what I do. I use wet gauze, mate.
Yeah. This is what it's all about. Is dentistry is all about what people are doing and because to get it consistently and understand.
Can you see this?
Yeah.
Yes. Yeah, it's come up.
So, this was a closed sinus lift, which is probably it's 90% of my placements. I rarely do laterals now, with the DAS kit. But what I use an osteotome I've done the initial lift with the DAS kit to put the Ethos up there into the sinus. Then what I do afterwards is I use damp gauze with a smaller osteotome and compress it up even more. You know what I mean? And I find as though doing it that way, it dehydrates as well as compressing, if you know what I mean. And you get quite a nice ballooned kind of outcome with the gauze, and also the gauze is pretty soft and safe. So that's the way that I do it. Is I use a bit of wet gauze on the end of a smaller osteotome. So if you go up to say if this is a 4.1 Straumann tissue level, another just on a side note whilst on this is tissue levels as well. If you want to add even more safety to your sinus lifts, then the tissue level design, Southern
Don't push it in.
with them, is you with the tissue level tulip with the collar, it's so difficult for you to lose that implant into the sinus, to the point where you'd have to be really kind of going at it purposely to stick it in the sinus.
That's a nice lift, Andrew. My question always is, would you not use 2 millimeters more in length, or does it not bother you? Because I know this is like, if I had to say what's Andrew's protocol, I would say this is something that is very unique to your working. You just do this all the time.
I don't really see the point. What I find is though it compresses down anyway to that. Now maybe I would have, if you look at the Boston picture at 3 months, I would have had some more bone around the 8 millimeter. Sorry, around the 10. This is an 8 mil. This isn't a 6.
Yeah.
I you know what, if you ask Steve Schnuck, my orders are literally all 8 millimeter implants. I just don't.
Yeah.
I've unless I'm going for immediacy and immediate loading, especially, and I'm going past that socket length or whatever, and I'm up into the 12 or 13s or whatever. But for standard placements, molars, even if I've got 12 millimeters of bone in the lower mandible to place between two adjacent molars, I would still place an 8. Because I don't see that.
Yeah, I mean, this is very much of what you do, and I've seen it, and you do it, because it's successful. You're not doing it because you're doing it because you're getting routine success from it. Yeah, I mean that's a big thing in change in length. What do you think, Jenny? I mean, shorter implants are here, aren't they?
Yeah, they're here. I personally use kind of 8 to 10 millimeters. I don't use massively long, but I can share my screen and show you.
Yeah, sure.
This will stop this. Bear with me. Just trying to find it. So can you see my screen?
No, not just yet.
No?
No.
Has it come up and share your screen?
Bear with me. Yes, it has now. Share. There we go. Can you see it now?
There you go. Yeah, that's it. Yeah.
So, this is on a CBCT scan, not a lot of bone there. And I would struggle traditionally. I'd look at lateral lifts. But in terms of my technique, in this scenario, I wanted to preserve the bone. So I used a very small trephine really to create the initial site location. I use
you like osteotomes as well there.
Yes. I've started using the Versa burrs, the osteodensification burrs. In terms of Ethos application, I tend to mix it out with a bit of saline. I don't really measure or titrate the ratio to saline to Ethos, but I give it a good mix, and then I dry it out with gauze or a bit of tissue, so I get a really dry mix. I find it easier to manipulate then and scoop this up, because I find the surgical site is quite wet anyway, so you need a really good dry mix to be able to pack it into the site. And similar to Andrew, you use whatever tools you can. Smaller osteotomes are really good, but it's a drier, crumbly mix there. And then I pump it through. This is actually an 8 millimeter, so it's quite short, like what Andrew does, and it works really well. Sorry, that's another case, but it works really well. And then gauze over the top of the surgical site and suture over.
I don't see why you'd be going to 12 millimeters now, especially into sinuses, really.
Yeah, 8 to 10 is what I do. Yeah,
I think 8 to 10 is my, unless, like I say, I'm going for immediacy, but And
So
also,
there's
there's more advantages to it. I think there's a lot more evidence to say now the shorter's a way to go. And secondary to that, if you ever need to remove the thing, you know, you've got something to work with afterwards, you know. And it's, yeah, I think there's more benefits to using short implants now than longer ones.
So,
And I also think it's,
so sorry, go on.
I also tissue levels. I know it's a lecture that I bang on about, but I do think tissue levels are the way forwards, and I think that's going to be proved in the next few years.
even AnyRidge has just launched a tissue level.
Of course they have.
Oh.
Up with EthOss.
Yeah.
Right,
I mean,
the next question, Stu.
The safety margin is there, and it's still on the topic of height and things like that, and tissue level will come into this as well. But what is the minimum height that Ethos can be used in a Crestal augmentation?
I've done it on 2 millimeters.
Yeah. You know, this is down to the skill of the dentist. It's like, it's saying, how fast can you fly a supersonic jet if you're not a pilot? You know, you develop your own skill and your own safety zone. And again, it's the implant type. Whereas AnyRidge would be difficult to place in 1 millimeter, and I do, but it's very difficult. What Andrew is doing with tissue level, it's not a problem.
It really is.
So therefore, flared tulip design.
Yeah, you know,
helps.
so yeah, you're not going to. It's much harder placing an implant which is designed to be placed 1 to 2 millimeters subcrestally when you've only got 1 millimeter of bone. So yeah, so the tissue level implant concept makes a lot of sense when you get to this situation. Yeah, should we go onto the next?
So the next one, Jenny, I think you could answer this one. The question is, how successful is osseodensification? And please can you advise about Densa and Versaburr?
Yeah, they're a great set of burrs. They do some training along with the purchase of the burrs, so I'd certainly recommend that. It's good value. Effectively, you are spinning the burr in reverse slowly, and it as opposed to removing the bone, it spins the bone upwards in a cushioned force manner. So there's very little risk of tearing the sinus. So using the host bone, and then in order to do the lift, I combine that with Ethos, really, especially in cases where there's very little bone to begin with. Because the Densa Versaburr protocol, I think it's minimum of 5 millimeters, 4 or 5 millimeters you need. So in cases where there's less than that, this is where Ethos really comes into it. I use the burrs to spin the Ethos up without water, very slowly into the region. For me, it's worked really well, the combination of Densa Versa with Ethos. It's been a game changer. I'm doing a lot more sinus work myself, and not having a mentor or anyone else do it. I think the fear was, I can't emphasize enough the beauty and the safety of Ethos as compared to xenografts, especially in that sinus region where medical legally the litigation is you know, quite fraught there, really. So yeah, hope that answers the question.
Yes. Yeah,
Andrew, are you using Versa in the sinus?
No.
I'm
not willing to spend another 1,500 quid on something that I don't really need. So
yeah. You have the skill.
Yeah. So the DAS kit is really good. I like the DAS kit.
Yes.
You know,
now,
it works.
We were talking about this, weren't we?
Yeah, I mean, my experience from sort of a new pair of eyes, I looked at all the kit that I had and I thought, that Densa Versaburr kit is so nice, small and compact. I really want it to work well. So I tried to use it for my first sort of 2 cases using it. And I had really small tears with it, even though I was super careful.
Really?
And Pete was just like, dude, why aren't you using the DAS kit? And I looked at the DAS kit and I was like, oh, compared to this small Versa kit, that DAS kit just looks like more stuff to have on my tray. And so I persisted through those first 2 cases with the Versa, didn't get results. And since I've been using the DAS, it's just been perfect, plain sailing.
It works. It just makes sense, doesn't it? I mean, if you're sticking all the water in front of your drilling end, you know.
Yeah, I use a combination, really. As with everything, being you know, trying to make everyone happy. No, look, I use a combination all the time. I start with Dask and then switch to Versa once I've done the initial one.
I think that is the sweet spot. Using the Dask to lift the sinus,
Yeah.
and using the Versa just to help
Drive the
gently
material in.
nudge the ethos up in.
Yeah, I see guys that are good friends of mine that use Versa a lot. It obviously works, and it works okay, but with those people's X-rays that I'm talking about, I won't name names, but there's always a little bit of squirt.
Yeah.
You know, it's not a neat lift, if you know what I mean. And
How do you get such a neat lift, Andrew?
but it doesn't matter, and it heals the same, and it's all good. And all
Yeah,
that
yeah.
stuff, but just for my,
It's good.
my clean eye.
Yeah,
It's
Andrew's looking at our dirty laundry.
Yeah,
How do you get such a neat lift, Andrew?
with Dask and the gauze on the end of my osteotome.
Yeah, that's it.
That's it.
Yeah,
I go to the sinus floor with my normal drilling sequence. I'll go as far as up to a 4.1. Then I'll go on to the smallest Dask with the depth stop on, and just pop through. And as soon as it pops through, then I'll go back to osteotomes, and I'll put the gauze on that's wet, and I'll just lift it. So I'm lifting the side. I lift the Schneiderian membrane with wet gauze and osteotome. I assume that's how I'm doing it. And then I'll put the ethos in, pack it up, then I'll put my wet gauze osteotome up again to lift more ethos. Then I'll put my implant in, and it is I consistently see doming of my lifts, and I think it just goes. It makes sense. It's soft. It's it's not gonna.
It does. I've not used the gauze to lift the membrane, but I've used the gauze to lift the periosteum, and I always get a really nice clean lift.
Yeah. So that's exactly why I use gauze, because I've done it. I use it for lifting the periosteum sometimes too. Yeah.
Sure. Should we go into the next question?
Yeah. So there's a little delay between me opening them up, so I'll read that. So next one is, what is your complication rate for sinus augmentation, and is the premium charged by indemnity insurance companies justified?
0, and no, it's not.
Yes, totally, Andrew.
Easy answer.
0. It's one of this. It's possibly the safest thing I do. I mean, it's a complete misnomer that somehow sinus augmentation is going to kill your patient. I mean, it's just ridiculous.
It's absolutely unjustified.
Yeah. I mean, it's just a money making. I don't know. But having said that, I was out lecturing, and a great friend of mine, we were at the pool together in India, and he was talking about his infection he had in the sinus, and how it took a year, and the anxiety, and it's still not sorted. And yes, if you have an infected sinus, it can be an absolute nightmare. But I've never had one, so I don't see what it's all about.
I mean, that probably comes back to what's being put into the sinus as well, doesn't it?
Yeah, I mean, that's just logical. Anyway, next one, Stu. What do you think, Jenny? Ridiculous, the indemnity?
Yeah, I think it's pretty safe with fine. But it depends with who you're with. Recently, I discovered if you're doing...
Yes, you brought that factor up in Scotland, and that's very important. It depends who you're with.
Yeah. And if you're doing lateral, they tend to charge, whereas if you're doing internal, the way Andrew was saying, predominantly all these cases, my cases are, you don't pay any more, actually.
I changed to private indemnity about 4 years ago, and they've not increased my premium because I do sinus lifts. So, well, it's under category OMFS1. It's under, if you've got private insurance, it's OMFS1, which includes a lot of things, really. Some of the things that I don't do, but it's a remarkable saving moving from a union to private.
Yeah,
less than half I pay.
So the next one here is what is your protocol for patients that present with sinusitis?
Refer them to ENT.
Yeah, I think the key is to find an ENT that is very dental friendly, because a lot of ENTs still don't quite understand what we're doing. And another reason for the sinusitis can often be the infected tooth that we've just taken out, or something along that line. So yeah.
Yeah, so at what point are you referring to the sinusitis? Pre-implant placement or post? You know, you have to look at other causes of pathology.
Just a sort of vague sinusitis in the question.
I think if it's post, I think it's probably more relevant for us to answer if it was post.
Yes.
You know, if it's pre, obviously you go to GP or whatever else. So I think if it's post sinusitis, I think I've seen something recently on Facebook. It was a friend of mine. She posted us what appears to be a radio opaque area in the sinus on a PA, and she was asking, you know, what is it? And it could have ranged from anything from the buttress up to like an anthrolith or whatever. You know, and it still gets to me how many are advocating CBCTs, you know, to establish what it is. You know, when ENT would not do that, they would visualize it with a scope. You know, you know, so I think it's important that we don't start imaging these things when we're going to refer anyway. You know, we take a CBCT.
I know.
We see something in D that's radio opaque. What are you going to do? You know, you're going to refer anyway, and what you've done is if you've cost the patient more money probably because you've CBCT'd and an increased amount of radiation dose, which, you know, I know it's a pet peeve of mine, like the overuse of CBCTs, but I think it's important to have this relationship with an ENT person, like you said, Peter. And you know, I've got a guy here called Russell Cathcart who's a friend, but he's a really good ENT guy, and I refer a lot to him. You know, I've just had a patient from South Africa come back with sinusitis actually around a really aggressive looking placement, not as in surgically aggressive, but the implant design is like super sharp thread pitch, you know, and all this sort of stuff. And I suspect, you know, when we're talking about sinusitis as well, graft materials obviously play a role, whether you're not using a xenograft and all this stuff. But I also think implants do as well. You'll see a lot of clinicians placing implants, as we've said, without any sort of grafting. But the implant designs must make a difference. You know, if I'm using a Straumann tissue level, it's got a really kind of minor thread pitch. It's a round-ended implant. You know,
that's very safe.
You know, or I start going towards these kind of, I don't know, maybe not so much any ridge, but there are some up there that are really kind of aggressive in the thread pitches. Anyway, so Russell scoped this guy and he could see the implant and it was a bit inflamed on the tissue, you know, and it was actually that causing the sinusitis. You know, it wasn't like an infection, but it was this low grade edematous response where the cells within the sinus were continually creating a mucus, which was giving him a postnasal drip. And that was it. So we took it out based on that kind of what he reported. You know, it was fine. But you know, I think when deciding when doing sinuses, I think your implant design is important too. That's about it.
Right, Stu, next one.
So next one, what is the procedure to deal with a possible oral antral communication formed due to a failed intracrestal implant?
Same as the tooth.
Yeah.
Yeah, it's normally the tooth that's going to lead to oral antral. Yeah. I have pulled out a fair few number of implants out of the sinuses over years as well, and if anyone does, just always find someone who can do it for you, just to get it out nice and quietly without anyone knowing about it.
If it's a small one, then I'd often use a collar cone. I do a lot of referrals for just normal tooth-related OACs. And if it's a small perforation, you know, it's kind of a non-healing site because of an OAC, then collar cones work quite well. Really good instructions with regards to nose blowing, all that sort of stuff, and sneezing. But beyond that, then you're looking at the buccal, but I would actually favour the palatal advancement flap over the buccal advancement flap. It's a bit more technically daunting to do, but you'll have a lot better robust site for healing if you do a palatal.
Yes.
I see the next question's up there.
Yes, I've got another one for you, Andrew, here. With the advent of shorter implants, are augmentation cases decreasing, or is this just marketing tactics of short implants?
No, they work, and I could. I've got. I've just was looking back actually through some of my cases. I've got one that's ridiculous, and this is now a 7-year review. So I'll just show you this one very quickly.
Can you share the screen again,
Yeah.
Stuart?
This was 2.6mm, 4.8 by 6. Immediate placements of tissue levels again. Lovely health around the collars. That's at 2 years. And well, yeah, this is an older lecture, but they're still there, absolutely fine. I see this lady. That's all Basil Mizrahi's work, all the crowns and stuff. And they look insanely ridiculous, you know, if you look at them, you know. Then I've got loads of short ones. Like I've got one that I often show, which is the
soft tissue always looks nice around those tissue levels.
Oh, it's insanely good. I honestly don't know why people don't use them more. Like this was one I did that I always do in my lectures, you know.
Yeah, this is the one that always interests me.
Yeah, and this is still there now, and this was placed in 2016. You know, and the reason I did this is because of that bone loss on the 7, and she didn't want to lose the 7. So I thought if that periodontal status ever had an impact on the implant, at least I'm only removing 6mm of implant, you know, and I can always put a longer one in. And she was right in me not removing that molar because it's stable as anything, and she's a hygienist and all that sort of stuff, you know. But you know, for me, short implants work, and they work really well. So obviously, with the advent of short implants, I don't believe they're a marketing tool. I've been using. I was very. As a surgeon, I'm very risk averse. I don't like pushing the boundaries too much. I figure it's not fair on the patients to do so. So if I was ever near, you know, lower molars and stuff like this, I would often place shorter just because I was worried that I might inadvertently nick the inferior alveolar nerve or something else like this, you know. So for me, they work, and of course they're going to reduce the need to augment. So if you can, I wouldn't go for a 6 though. So if it was a decision between a 6 and an 8, with an 8 with a little bit of a close sinus lift, I would go with an 8, you know. But if it came to 6s or 8s over a low molar where you increase morbidity risk of damaging the inferior alveolar nerve, then I'd maybe splint some 6s together, you know, quite happily, or even 4s.
Yes. Okay. The next question is a good one for you, Pete. Is it okay to use Ethos against the implant surface when performing the sinus graft and placement of implants in the same visit?
Yeah, as you well know, I often don't have any host bone against the implant when I place it. So that, you know, I've got no problem about placing with 0 bone to implant contact. And that's on lower 7s. And I haven't had a, you know, they've all worked. So the idea that bone touching the graft material, because the graft material fully turns over, is turned over to host bone, it doesn't make any difference whatsoever. We did a lot of other research using synchrotron CTs as well, but you know, that's too long to go into that. Stu, I've got two or three cases or 3 or 4 cases. So if I share just for 2 minutes, and I'll go through some just to get the conceptual ideas, and then we'll go straight back into questions because we're on to about 20 past, so we can go from there. So if you just let me, I'll share, and I'm just going to go from there. There you go. Right, I like this picture just because it's a good picture. And the whole idea of ethos is ethical bone, and you know, that's another funny little thing, is that we always say that people don't mind, but they actually do mind. And maybe we should take a little bit more care on what our patients say. This is just a sinus paper I published at EAO and Koya in 2016. And here they were all loaded at 8 weeks. So using Ostel to take the readings for success. So It's an interesting thing. They were all lateral windows at the time. But what I really want to get across is this area here. Can you see this area? This is the important area in a way. And all I'm going to do is place an implant in the mesial site, as you can see here, and then graft these distal sites where all this bone's missing. Because what I want to do is restore it back to this level with keratinized tissue. And this is the situation. You see perio teeth, that's after removal. You can see the bone loss. Place the mesial implant, grafted the distal site. 10 weeks later, now you can see the good bone distally, and you can see the improvement in the soft and hard tissue already. Then using Versa, just lift it up, place the distal implant. There it is here. And then loaded it. There it is loading the mesial one and then the distal one afterwards. And here it is here. And what we have is this increase in vertical tissue. So we get a better looking restored situation, because now we have 3-4 millimeters of this keratinized, attached keratinized tissue and vertical. So you see, taking that from that to there, it's not what I'm doing in the sinus, it's what I'm doing above the sinus as well. When we look at it in the hard and soft hard tissue, you can see that change. And this was just an interesting case I wanted to show, because, you know, it's just a normal sinus with a lot of bone loss. Yeah, I probably should have taken that bridge away, it's too thin. But then I place and graft, and for about 2 weeks, 3 weeks, she just wouldn't heal. Eventually it's healing by secondary. And it looks like I'm I've lost a lot of the graft material. And this was the problem. She had the AstraZeneca vaccine, and it pointed out a fact that she had a hereditary clotting disorder. And this was stopping, obviously, the healing. But anyway, it didn't matter. Here it is restored. There it is there. And as you can see, we've now got an adequate outcome with this case from before. And I do this a lot. You can see in this particular case by actually socket grafting first. Here it is at 10 weeks. So we've restored the ridge. There is the bone underneath. And then this is the way I like to do. Touch with DASC and then use Versa. So I've already just lifted with a little bit with DASC, and then I use Versa to drive it in. And here it is loaded 2 years. So you can see when you've got fully bioabsorbed materials, you can see the change in the tissue and the striations and the bony formation. I won't show this, just a video showing. But also, we must always remember that we've always got to learn how to do lateral windows. And DASC, again, is the key here by just doing the osteotomy on the top. As I'm placing the implant, you can see it's driving the graft material out the lateral window, seal the lateral window up. There was 2.5 millimeters. And the interesting thing in the before and after. So this is loading at 12 weeks, and you can see we've already got a new cortical plate and a significant. As to infected sites, this is one I always show where we had multiple oroantrals, and basically there was pus coming out of the side. This is sealed with Ethos. That's a lateral window oroantral. This is 8 weeks later. That's a lateral window. That's our oroantral communication. And it was only 8 weeks later, and we now have 10 millimeters to place the implant. So let's just go back, and I'll stop share. And, you know, just a quick look at a couple of things. And what I'm looking at the moment is how to improve the cases.
Yeah, those are nice cases, nice slides, showing it's not what's happening in the sinus, but also what's happening just outside it.
Yeah, it's a bit of both. Anyway, let's go into the next question.
So this next one is some of my grafted areas with Ethos fail, especially when I extract and graft and place a collar plug and suture. Please, can you advise on how to overcome this? So this is sort of coming back to the ridge preservation and sort of delayed type approach that we quite like in terms of using the soft tissue to cover your grafted site.
Is there enough bleeding? That's got to ensure that there's blood in the socket. It's not quite dry.
You know what? I got involved in this argument years ago with Graft, and we were at Zurich University, and we were doing something, and we had a whole lot of people there. And the problem is that socket grafting is seen, ridge preservation is seen as the easiest thing you can do. Every dentist should. No, ridge preservation is actually about one of the hardest things you can do. And so I agree, and I agree with Andrew here in that if we're going to ridge preserve, rather extract the tooth. The patient's gone through enough trauma, let it heal for a couple of weeks or a month or so, then come in and deal with the situation. Ridge preservation is actually more difficult than we think.
Just that approach that we're taking, the early delayed, you're still preserving the ridge. You're just benefiting from the healing potential in the periosteum of the soft tissue that's now covered the extraction socket.
It's also the infected nature. You're invariably taking the tooth out because it's acutely infected. And then people put graft material, whatever the graft material, they put it onto an infected site or onto a granulated site because they haven't cleaned, you can't clean it properly. You've just pulled someone's tooth out. It's bleeding everywhere. This is one of the hard things to do. And therefore taking a bit of time. It's not a bad thing. Just let it heal for a while.
Yes.
You agree, Andrew?
100%. Yeah, 100%. I think it just makes so much more sense biologically, and you're gaining tissue as well, which is a huge bonus. But you've got a clean site. It's clean because it's healed. So and then deal with it and then graft afterwards.
I mean, I can remember asking Pete a while ago, I was like, how much do I have to degranulate these extraction sockets when I'm taking these teeth out? He was like, well, you have to degranulate what you can see, but if you're going to go back and place an implant in 5-6 weeks, you're going to be opening the site up. You're going to get a real good view of it then. That's when you can have a good look and make sure it sort of definitely is all clean. But using the body and letting it heal so that you can use that healing potential in the soft tissue.
As Clint Eastwood said, you can be lucky, but do you want to be lucky? What is it? Something about, do you feel lucky, punk?
I have got some good cases from ridge preservation point of view, which I did many years ago.
No, it works.
I presented at like the Leeds Armoury and stuff like this, but they weren't predictable. It's not a predictable way of doing it. That was my issue.
That's the key, Andrew. Is if you can get up and do the same thing every day. And never have a problem. That's the predictability. And the moment you have this infected, it just throws a little error of unpredictability into it. That's out of our hands because it's in the hands of the patient's physiology.
Exactly.
You agree with that, don't you, Jenny?
Yes, absolutely. Predictability is so important.
Yeah. Right. The next one.
The next one is, what is the protocol for using a drier mix over a wetter mix?
Well, not really. This is just a habit that I have. It's not a protocol because I haven't published it or anything, but it's just the idea of having a wetter mix. It gives it a little more flexibility deeper down, and a drier mix gives it more rigidity on the surface. I mean, and the wetter mix stops you over compressing the material deep down, and that's the problem.
It just runs into all the defects,
and you can't compress it; it's just running. And I think that's the safety factor that Andrew was talking about over compressing material deep in the socket. If it's wetter, it's very hard to do that.
Dry mix is important on the surface because that's what helps the future. So you need that.
Yeah, it just helps you get stability and a set. The interesting thing, just going on to it, I'm just really, my head's full of meshes at the moment and ideas. Nicholas Widmar's lecture was, some money. Nicholas Widmar's lecture was very good. and I've also been seeing some really interesting things, and I'm looking at different ways of doing meshes with different materials now. So it will be interesting where we go over the next while. Anyway, that's by the by. Stuart, next question.
What are your thoughts regarding needing PRP for use in sinus augmentations?
I didn't think anyone used PRP anymore.
Do they mean PRF?
Yeah,
I mean, it says PRP, but I suspect they could have meant PRF.
I remember a very good colleague, and he used to drag his PRP machine around everywhere on his visits, and
Jamal used it for a bit, actually.
yeah, it was good exercise carrying the machine around.
Yeah.
I
I think with regards to PRF, if it is PRF, I don't. Again,
look, anything works in the sinus.
yeah, I know it's one of them things that you can use, and anecdotally, you might see improved soft tissue healing and stuff like this, which I know quite a few clinicians that do use it would say there isn't much evidence out there for it, and it's just another expense and pain in the ass for me when I don't really need it. So just mix it with
sort of, trying to keep things simple and straightforward.
Yeah, it's just I don't.
Yeah, look, it's essentially the body is the one doing the healing.
Yeah, I could see its potential use over zygomatics and stuff, like over that kind of exposed implant going through the malar. But again,
I've not done PRP, so I can't comment. Not had the need to use it.
No, it's the same.
There's a question here that says, do you think that we can achieve adequate vertical sinus augmentation with osteotome bone graft techniques?
Yes.
Yeah, there you've got two big supporters of osteotomes here, I could see.
Yeah, obviously.
I think we've covered this one in an
Yeah, I think we have out of the three of us, we have two of us are very firm supporters of osteotomes. I think Mukesh is another one. He loves osteotomes. Yeah,
good tactile feedback. It's quite safe.
It's a good old-fashioned way of doing things that and it's a skill, and you just develop it, and it becomes.
I don't think you shouldn't need to use the hammer if you use them in conjunction with the DAS kit.
Yeah.
And just a push and a squeeze.
Yeah.
Yeah.
I rarely, unless it's a very soft posterior maxilla, I wouldn't use them usually to make my osteotomy. I use them purely to lift the sinus membrane with the gauze and introduce the ethos up into the sinus.
Next question. Does native bone occur with long-term use of ethos in the sinus?
That's all it can be.
2 months, then of course it is.
Yeah, it can be nothing else.
Robert Retty will tell you that it's gypsum. But,
yeah, well.
It's.
I mean,
if it's stable and if it's healthy and if it's good, is that any worse than cow bone? So.
I mean, the contrast between looking at an ethos grafted site and a xenograft grafted site is that with the ethos, you see 2 to 3 millimeters of really condensed, sort of almost like cortical floor of the sinus plate bone around the apex of your implant.
I've got some nice cases to illustrate that. You get really good densification with ethos, whereas I've got quite a big sinus lift case with 50-50 xenograft autogenous. And like I say, it looks a bit like bone, but it's very hollow in appearance.
Yeah,
it looks nice on the radiograph, but functionally.
Yeah, exactly.
Yeah, I mean, that's logical, and I mean, all doctors know that, so we don't really have to debate that. The best thing is to have your own bone, and the only way to have your own bone is to have a fully bioabsorbed any graft material you put in, whatever it is, as long as it's fully bioabsorbed.
Yeah.
That's simple, especially in the sinus.
Next
and
one is,
I
do
think
you use...
any ENT would back you up. I mean, I think ENTs are quite shocked that we put non-resorbable material in the sinus. Yeah.
Absolutely. Yeah.
Anyway, that's.
Yeah,
this question, basically, we use ethos and not sticky bone.
Yeah, look, you know, some of the ideas of sticky bone are great if you're building buckley, but again, I'm not so sure about in the sinus. You know, we're dealing with a tricky area. I mean, everything works. You know, I often say in all my talks, the body heals despite what we do. And that's it. So we want to do as little as we can. We want to do what Andrew does, go to the beach, chill out, hang with the family.
Anyway, you've got a good tan, Andrew. Next one.
Yeah, that's one. I'm envious of Andrew's tan. He's definitely been at the beach.
What about tan, eh?
And I was supposed to be meeting a mate for a surf at 8 o'clock. So
sounds good. Next one is, normally I use sinus graft material of large particle size for space maintenance. Is this possible with Ethos? I think this comes down to what we've just been talking about in terms of Ethos's functional turnover rather than just space maintenance.
Yeah. If you want to space maintain, then you just put anything, big particles of stuff that's never going to go away. But all it's doing is taking the place of host bone. And so it's not logical. But as dentists, I think we become fixated, not about biology, but about what we can see on X-rays and CBCTs, which are of no value unless the material is fully bioabsorbed. I mean, what's the point of taking a CBCT of a xenograft? I mean, you can't tell what type of animal it is, so it doesn't have any value. So that, you know, there's, unless the material's fully bioabsorbed, X-rays, post-operative X-rays are of no value. You're just taking a picture of the foreign material. So yeah, it depends what you want. If you want to see how the cow's doing, yeah, big particles are great. Anyway, okay, next question, Stu.
That was the last question. Let's see if we've had any questions sent in. There's another question that's been sent in. Someone's asked if we put a membrane over a lateral window.
Yeah, look, my research shows that if I put a membrane over the lateral window, I'm going to impede the healing of the lateral window. And the research we've done, the animal studies we've done, have shown that it actually decreases the blood vessels in the new bone by up to 50%. So the periosteum has healed bone for thousands of years in trillions of cases until a dentist came along and said that we need a collagen membrane from a pig to make the bone to heal. It just doesn't make sense. That's all. It probably works in us dentists' minds that we need a membrane over the window. But if you went to any doctor or any bone physiologist, they would say you've got the perfect membrane, and it's called the periosteum. It's the miracle.
I think it highlights. I think it highlights the difficulty of using a ceramified, sintered xenograft. Is that you need that membrane to halt the process of soft tissue ingress, you know, because it's an inert mass of nothing, you know. So, you know, whether or not it be bacteria, soft tissue, granulation tissue, anything's going to grow within it, you know. And I think that's
the
massive drawback that for me, you know. If I'm going to use them, if you want a material that's going to form bone, you know, and if you have to have a membrane to get that, then fair enough, but not to get a mix of stuff, you know. It's for me, Ethos has changed the practice in Elston for many years, and it'll I think it's the way forward, and it should be anyway for most implantologists.
I mean, personally, even some of the guys using the xenografts are now using membranes with holes in them because they're recognizing the healing potential of the periosteum.
Yeah, it's hard.
What about, no one's mentioned giant cell reactions yet, you know, foreign body giant cell reaction.
Yeah.
Anyway, that's another whole story with which I'm sure Mr. Albrechtsen always elucidates to. So it brings another whole debate into this table, and we probably don't really have time for that. So we've got some more questions here. Okay. Do you advocate perforation on the mandible, on the cortical plate? Look, I don't, but a lot of other people, a number of people do. And I used to always say if it was my mother-in-law, I'd definitely do it. But we you know, I'm getting on well with it at the moment. So I can't say that anymore. Okay, if I only ask, have there any cases where graft being pushed out of the sinus due to internal? Yes, you've always got to remember that when you're grafting in the sinus, especially without tacking a membrane on, you have to actually say to the patient, please do not sneeze, please do not do this. You know, I had a case where the guy left, I did a sinus augmentation, he left, he went straight to the pub, then a party, then a nightclub. And he phoned me off lying in the bath the next day, said, look, if he blocks his nose and he blows, you can hear a whistling sound. So yes, we are a little bit, we're a little bit at the mercy of our patients. And this is our big problem, is once people walk out the door, we lose control. There's another final question here about vertical bone height. Can this be achieved? Well, you know, again, this is down to your skill. I mean, just because I buy Tiger Woods' latest, or not Tiger, let's just say DeChambeau. I've just bought DeChambeau's latest driver. It doesn't mean I'm going to be able to drive 400 yards. It's not about materials. It's about the skill of the surgeon who's actually doing the case. It's a kind of like a skilled job that you just improve as you do more and more.
These are situations where ridge preservation, maybe that's when I would be doing it, but not in the terms where you've got an extraction socket though. So I would still allow soft tissue healing to happen.
Yeah.
Andrew. And then, but
Andrew,
then you have to do it again.
That's the take-home message tonight, I think, Andrew, is sticking to the protocol, sticking to the principles, especially when you're starting off, getting that soft tissue, getting that 99% success is a key.
Yeah.
Don't you agree, Jenny?
Simple.
Yeah, keep it simple, really.
Yeah.
Stu, no more questions. I think
that's it. That was the last one.
Good. And that looks about time for us to go back to the pub then, doesn't it?
Thank you.
Thank you.
All right, thank you.
Hey,
Andrew,
thank you, guys.
thanks a lot. Have a good wave, Andrew.
Thank you very much.
Thank you.
Thank you, Jenny.
Thank you.
Always good to see you. Right.
Yes.
Bye-bye then.
Bye.
Thank you to everyone who took part and for all the questions. It was great to have you. And nice to see you, Jenny.
You too. Thank you. Bye.
Bye,
Take care,
guys.
Bye.